I'll just quickly go through and show my it may be performed twice a week, a gap of 3 days. And epilepsy is not a contraindication. It is not a so epilepsy has been found to be treated with ECT itself. In patients who have not taken anticonvulsant, the seizure thresholds are expected to rise through the course. So ECT may be given to epilepsy patients, but treatment with anticonvulsants may increase the baseline seizure, resulting in high energy. And ECT is generally considered not generally considered for patients with schizophrenia unless there is an affective component, and the contraindication is also not for people less than 16 years of age. What are the relative contraindications? Myocardial infarction within the last 3 months, or unstable angina, because we saw what are the effects on the cardiovascular system. Cerebrovascular event in last 3 months, because it raises the intracranial pressure and the cerebral blood flow. Raised intracranial pressure or untreated cerebral aneurysm is a contraindication. Unstable major fracture or cervical spine injury is also another contraindication. Patients with pheochromocytoma, because after the initial parasympathetic activity, there will be sympathetic activity. So that time it may produce a very severe hypertension and tachycardia. Uncontrolled cardiac failure or severe valvular disease is also another contraindication. Patients with history of previous deep vein thrombosis, they are also not good candidates for this. So how to administer some of the tricky conditions? If patients have cochlear implant or other brain implants, they pose a challenge for that. But in these patients, they have done unilateral ECT, has been successfully given for patients with cochlear implants. And the ECT is safe with pacemaker patients. What are the precautions you need to give? You have to admit ECT can be given for patients with pacemaker. Only thing you have to convert them into anti-tachycardia function and you can reactivate it after the ECT. So you have to nullify the anti-tachycardia function in that. Is ECT safe in pregnant patients? ECT can be used in pregnancy-induced depression also. What are the challenges in ECT anesthesia? It is a NORA procedure. So all precautions pertaining to it must be adhered to. That is, it is a newer procedure. You may not have adequate helping hand. You must check the machine because the machines may not be routinely used. So the cylinder supply, you have to find out whether the oxygen is coming from the central pipeline or the cylinder. Sometimes the cylinder may be empty. Always check for the presence of an ambu bag in case of emergency. So all that thing you have to check for, and it's a brief due to short nature of the procedure. The aim is to provide short duration of unconsciousness and adequate muscle relaxation. The return to consciousness should be rapid and full orientation is desirable. Postoperative nausea, vomiting can occur and should be managed by prophylactic medications. There should be designated recovery area with monitoring till the patient is fully awake. So it will be given in a room, the equipment for the ECT, and then patient will be shifted and he has to be monitored till they are fully conscious and awake. The commonly used induction medications for ECT are etomidate. Vitamin also has been used sometimes. Methotrexate is the preferred drug. Propofol, rocuronium, and these are the induction agents. These are the relaxants, rocuronium and the phenylcholine. And but the dosage is much smaller. What is called the subparalytic dose is given, so that you just want a amount of muscle relaxation and not full apnea. And so this is the bite block, oral protection to prevent tongue biting or tooth fracture during seizure. And who all make the team of ECT? The psychiatrist, the anesthetist, the trained nurses, nursing aides, and the ECT assistant. What equipments are needed? articles needed for the anesthesia, suction apparatus, face mask, oxygen cylinder, tongue depressor, mouth gag, resuscitation apparatus, full set of emergency drugs and defibrillator. And electroconvulsive therapy during COVID time. Sometimes I think on short note was asked how do you give ECT in COVID patient. So you have to first choose the correct patient. A symptomatic SARS-CoV positive patient should not undergo ECT. And if SARS-CoV positive, wait 14 days after the subsequent negative test. In airway management, positive pressure mask ventilation is often a common practice during ECT. This practice may risk viral aerosol generation. So practice minimize positive pressure mask ventilation should be continued, and minimizing masking strategies. Avoid hyperventilation, consider glycopyrrolate use, consider antitussive strategies to prevent the patient from coughing, and use a negative pressure room if possible. Recover patient in designated area with surgical mask. Allow 30 minutes between patients and treatment. So this is something I thought useful because now this is what is happening during a unmodified ECT. What was introduced, the patient is conscious, so he is wincing very badly when the electrical current has been given. This is modified ECT. Patient is happily sleeping. So the key points here are ECT is usually administered at remote locations. Modified ECT, use of anesthesia and muscle relaxants is the recommended standard practice. Full anesthetic assessment with attention to aspiration risk is essential. Adequate trained staff and appropriate equipment is imperative in creating a safe practice environment. Okay, so these are the things that we have to